no variant identified, then we sent for whole exome sequencing. And well, if the result was positive, then we sent for genetic counseling, and we started genetic counseling. If no variant was identified, then we think of reanalysis later on, or doing a more comprehensive test. Well, I don't need to go over this, but simply, if a normal person comes, we start by testing the affected relative, as we've seen in our example, and if positive family history, and or if the mutation was known. If they came with a known type of mutation, then we test for this targeted mutation. So, the most important part in genetic counseling is to give the information to individuals in very simple terms. We use a language that patients can understand. Even sometimes children in high schools and middle schools can understand the way we explain the information. So they can benefit from what we are saying. We explain what's the risk associated with each gene. Then after the post-test counseling, we explain when the results come back, we explain the pattern of inheritance and the risk for other family members and the surveillance. So, and also explain what is the difference between hereditary cancer and sporadic cancer. Why do some people, how can you tell that this person could have hereditary cancer syndrome? Because they are diagnosed early in their late 30s. Why is sporadic cancer? They are diagnosed most of the time after in their 60s. So because those people with hereditary cancer, they are born with one non-working gene. But with getting exposed to environmental factors, the other gene stops working, and this is where they manifest the disease. While people with sporadic cancer, let's say this person was a smoker, he will use one of the working genes at the age of 30, then he will not develop this type of cancer now, but later on, after the age of 60, when he keeps getting exposed to this environmental factor, he will use the other copy of the gene, and this is where he will manifest the disease. It's very important that we explain the options of surveillance. This is what the main goal of cancer genetic counseling is: try to prevent this individual from developing cancer by going for colonoscopy. If there are any polyps early at age, we can just help by removing these polyps. We can tell about chemo prevention, prophylactic surgeries like what happened with our patient. For example, if the patient is at risk of colorectal cancer, we explain that he has to be annually go through colonoscopy every 1 to 2 years. Endometrial cancer, he has to be screened annually, and so on. And in each disease, we have surveillance guide that we follow. This is a very interesting complex scenario that we're going to end up with. My talk with it's a 33-year-old female who had a history of 3 daughters who passed away with myelodysplastic syndrome. And they were requesting prevention. The couple came to my clinic, those 2 individuals, and they are concerned with this, and they told me about their 3 daughters who passed away. One at the age of 13, the other at the age of 6 and 5, and the third one was at the age of 5. And negative family history. It was very difficult to help them at that time, so what I decided to do is to do whole exam for both. I took that, I went through the family history. I found that the first one was she was diagnosed with pancytopenia suspecting myelodysplastic syndrome, and they were thinking of bone marrow, and the diagnosis was confirmed later, but the bone marrow didn't work, and the patient passed away after referred to the second transplantation. And she had cardiomegaly and precardial effusion. And they couldn't help her. The second daughter went to a similar situation, but the disease here manifests at the age of 5, and she had 2 cord blood transplants. The first was done as January Well, her third sister was the donor at that time. She didn't manifest the disease. When the third daughter also manifested the disease at the age of 5, and then she started deteriorating and she passed away. So all the three sisters were diagnosed with, three daughters diagnosed with acute myeloid leukemia, and all the results of the parents came back negative. That's the West, and also the NGS cancer panel. I told the mother, I cannot help you at this time. Well, I don't have any results that will explain what's going on. The mother later on came on pregnant, and she was requesting CBS, and we told her it's very difficult to help you. We have no results, but let's wait until you deliver and we see how can we take it from there. Well, 1 month later she came, and she told me that her sister-in-law had a pathogenic bad result. She started manifesting the disease at the age of 40, and she is in her 40s, and she had a result that says that she's positive for RUNX1 gene. And now the lady is 30 weeks, we cannot help her. So this was the result of the sister-in-law, where she was positive for a pathogenic variant in this gene, and it was an nonsense variant, and she had a chronic history of thrombocytopenia at the age of 41, and she was admitted for management and severe thrombocytopenia. Here we went back to the lab of Dr. Fozan, luckily, if you remember the case, where we had to go through the sample of the father and the mother again. And Dr. Fozan, thanks for all this, he helped us, and they rechecked both samples, and they found that the sample of the father was missed by the technology. Still, we cannot rely on the technology 100%. So, the father now is positive for the same variant, and the mother is wild type. And now we think that the daughters might have this variant as well. So we went and we tried to find what was the result of if we could get any sample of the three daughters. And was lucky to have one of the samples of the Leanne, who was 6 years when she passed away. And we sent also for whole genome sequencing, and she was positive for the same variant. So, according to Dr. Suzanne, it was fascinating, of course, the highly varied age of this family, and how some people can develop the disease early, some other people can develop the disease late, and this is what we should consider and look into. So I looked at this paper where it says incomplete penetrance for the RUNX1 gene, and also there was another paper that showed that another family had another nonsense variant in the same gene, and both the mother and 4 children were affected. This condition shows how complex sometimes it is to offer genetic counseling for cancer patients. Well, it's sometimes very difficult to find samples to explain what's going on, to help the mother while she's pregnant. And we have to explain to the parents that 90% of these individuals develop bleeding, but not 100%, and 25% they have myelodysplastic syndrome, and also about 50% they have eczema, and the penetrance is unknown, and they have to go through surveillance. And there are agents that they should avoid, and it is inherited in autosomal dominant pattern. So the important part here is the challenges in genetic testing and genetic counseling. So even now in the Middle East, we started working on making genetic centers and testing patients, but still, screening and issuing countries suspected for at-risk individuals for HCS is still shortage in the form of limited expanded gene panels. Not everybody can send for these tests. Deficiencies in the economy above the CS, which is the hereditary cancer syndrome, that clinical genomic sequencing facilities, NGS, is perhaps one of the major obstacles in the region. In regard to genetic counseling, most other countries have only recently implemented genetic counseling service, and within all the Arab region, we can say that we have up to 65 genetic counselors, but this society is a consanguineous tribal society which requires more attention and more facilities. And that, especially in cancer awareness programs, physician shortage, and lack of recommendations, lack of awareness in general population about examination and screening. Also, difficulties in getting medical appointments, utilizing the genetic germline screening at individual levels. Also, we have religious and cultural issues such as stigma, genetic illness in the Arab culture that makes it difficult for us. So I wish that if we, in the future, work more on having more genetic counselors, more facilities, with raising awareness in the society, we can help in avoiding having affected children with genetic diseases, and we can help those at risk of hereditary cancer syndromes. Thank you.
Thank you, Mr. Ahmed, for this amazing talk and really inspiring cases. I'm sure everyone here has many questions in his mind, but let us make the question at the end of the panel. So, please, it's my pleasure now to introduce Dr. Quran Khan. He is a research active consultant specializing in cancer genomics, immunotherapy, and targeted therapies. He leads gastrointestinal research at the Clinical Research Facility at University College London Hospital, NHS Trust, focusing in biomarkers, liquid biopsies, and patient-derived organoids. After training in nuclear oncology at Royal Medicine and Northern Ireland Cancer Center, Dr. Khan joined the UCLH and Washington hospitals, where he leads early phase clinical trial in GI malignancies and served as GI research specialty lead at the NIHR Clinical Research Network. Dr. Khan has authored several high-impact research papers and presented at international conferences, contributing significantly to advancement in cancer care and personalized therapy. He will give us a talk about screening patients and family members for cancer and precision therapies.
Thank you very much. First of all, I would like to thank the organizers for the very kind invite and the kind introduction. So, next few minutes I'll be talking about the somatic mutations that the previous speaker alluded upon. So we know that cancer is actually a genetic disorder, but it's not, in the vast majority of the cases, an inherited disorder. So, as per the previous discussion, 5 to 10% of those cases are only those which actually are due to an inherited germline mutation. So here I'm going to focus more on the precision medicine and oncology and how the treatment pathways are influenced. These are my disclosures. So whenever I've been offered an opportunity to talk, I think about 2 or 3 main take-home messages that I would like the audience to focus upon. So the first thing I would like to talk about is multimodal treatment and how it interacts with personalized medicine. And it will become clear in a few minutes, hopefully, what I mean by that. Then secondly, I'll concentrate on circuitry tumor DNA, which is one of the ways of establishing the genetic makeup of the tumors. And it has become more and more commonplace now in clinical practice to perform these tests. And then I'll talk about how we can work together to improve the outcomes of the patients. So let's start by discussing what multimodal treatment means. So So multimodal treatment obviously means that you have different types of treatment options, chemotherapy, radiotherapy, surgery, and you combine them effectively to improve the outcomes of the patients. The question is that how do we make decisions? The decisions are traditionally based on what we call as evidence-based medicine. And while it's great that evidence medicine is there, it stops us from doing silly things in the clinic, but there are some limitations. And one of the major limitations is that conventionally, we talk about evidence-based medicine and we associate it automatically with large phase 3 randomized studies. I myself a trialist and love the concept of phase 3 studies. However, what I will show you in the next few slides is that given the new developments in the field, better understanding about the biology of the disease, it's not always possible to have phase 3 evidence to support decision making. So we'll talk about why the tumor biology is complex and then what is the role of good functional multidisciplinarity. So this is actually one of the landmark papers with one of my colleagues, Charlie Swanton, that we published about 12 years ago. And this was based on just 4 patients and was published in the New England Journal of Medicine for very good reasons. What was demonstrated for the first time was that tumors are very complex. Within a single tumor, you can have heterogeneity, which means that if you look at the base of this tree, it may be the genetic drivers there behave differently to the branches of the tree, which is a very complex mechanism and makes the decision making for these patients very complex as well. So if you think more about it, what we rely upon generally in our clinical practice is the result of a single tumor biopsy. Or what we are dealing with is perhaps something which has different oncogenic drivers rather than the same oncogenic driver which would be the guidance pathway for us in terms of decision making. And that is where we are dealing with a very complex heterogeneous disease. So coming back to the second thing, what is personalized medicine? Now obviously, if you look at the simplistic way of defining personalized medicine, you offer anti-cancer therapy to X number of patients. What you want to see is that the drug is neither toxic and it is still beneficial. But that we all know does not happen in real life. So we have actually patients who are offered the drugs which are toxic but beneficial, which is the most common scenario. Then we have drugs which are toxic and still not beneficial. That also unfortunately happens for a lot of our patients. And then there are drugs that are not toxic and beneficial. That's what we want to achieve. But how can we achieve that? Because most of the times when we're offering chemotherapy or any other systemic options, they're not driven by the tumor biology. They're driven by the evidence which tells us what's the best treatment option for that group of patients. So my work actually over the last few years has been looking at targeted therapies in bowel cancer or other GI cancers. But I think the concepts of extrapolation remain the same, whether you're treating colorectal cancer or upper GI cancer or any other cancers, lung cancer, etc. Now we are coming to a point where there are lots of commonalities, and that's what we need to explore. So for example, if we concentrate on this pathway, what we see is actually this is a very common cancer genetic pathway, and all these oncogenic drivers such as RAS mutations, RAF mutations, K mutations, AKT mutations, they're shared by not just colorectal cancers, but a lot of other cancers as well. And these days we are coming closer to the concept of those therapies which actually are universal therapies for multiple cancers, which was not the concept that we are familiar with in the past. So that takes me nicely to the next step, which is the liquid biopsies. So if we go back to what I've discussed so far, solid biopsies have some limitations. And liquid biopsy, how can they be utilized? So first of all, what is liquid biopsy? We know that biopsy itself is the removal of the cells or tissue, which is examined by a pathologist. Now liquid biopsy is analysis of the circulating tumor cells, which are released by the tumor into the circulation. That's a simplistic way of looking at it. And then there's functional liquid biopsy, which is isolation of the living circulating tumor cells from metastatic cancer patients. What are the advantages and disadvantages? So this is a slightly old slide that I've been showing for the last 10 years, but incidentally, things have not changed dramatically. So we always knew that these liquid biopsies are less invasive. You are only relying on a single blood sample. The compliance would be possibly high these days because, compared to solid biopsies, which is an intervention, liquid biopsy is just a blood sample. These days they become more cost effective as well. Still expensive though, depending on which panel you are using. And they can be repeated at multiple time points, which is another important finding, because if you think about the cancer genetics, it evolves over time as well. So a patient might start off without a RAS mutation, and it may develop a RAS mutation later on, so you need to track that information. And you can't rely on multiple solid biopsies. Sensitivity is still under investigation. Clinical significance is what I will address. So the question that when I started my research at Royal Marsden Institute of Cancer Research was, should genetic information based on liquid biopsies enter clinical practice or not? So we all knew for the last 10-15 years that liquid biopsies and everything was very exciting. But obviously the question was how clinically relevant it is. And that's what I tried to address in my research. So this was the paper that we published in Cancer Discovery a few years ago. It was a very clean study. Those of you who have interest in bowel cancer will understand it better, but even without that interest, the concept was that we had actually patients who were treated with a specific anti-targeted agent called cetuximab in patients who had no RAS or RAF mutations. So in patients who have those mutations, they don't respond very well to these therapies. So we had several samples available. So we had the diagnostic tissue sample for these patients. We had the tissue biopsies at the baseline, the tissue biopsies at the time of response or stable disease, and then tissue biopsies at resistance, where then they progressed. And then what we did was we had 4 weekly blood samples, the liquid biopsies as well. Now, why was that important at the time? Because the question that was being asked was whether there was a strong concordance between the solid and liquid biopsies or not. So that's the first question that I wanted to address through this research. And what we showed was quite fascinating. So if you concentrate on this diagram, so you'll see that in this picture we have basically 2 different liver lesions which we biopsied. So, somewhere here. And you see that in both of those liver lesions, we are seeing very different pathology, different variability in frequency of different mutations. So if you concentrate on the right-hand side of the picture, you see that in the primary sigmoid, it's almost colorless. So none of these mutations mentioned on the left side are present in the primary. But when we see at the NRAS G12C mutation, it was present in both liver metastases, driving the resistance. But when we look at KRAS V141 mutation, it was only present in segment 2 of the liver. So what that highlights is the initial concept that I mentioned about the tumor heterogeneity, that even within the liver metastases, which were all coming from the bowel cancer, there was a difference in the genetic makeup. And that's a very important finding. So what we did was that we looked at individual patients, and because remember we were doing liquid biopsies on a 4-weekly basis. So what we found was that when the scans were showing that the tumor was stable, and the CEA, which is a commonly used tumor markers, also showing that the tumor had not progressed, we were able to pick up the evolution of these resistant clones in the circulation 4 to 8 weeks earlier. So rather than waiting for those scans, we knew that these patients would not respond to the treatment. And then different mutations led to different outcomes as well. This is another example of acquired resistance. This patient had beautiful response, you can see from week 0 to week 24. If you look at the scans at week 0, there is quite bulky disease in the liver, which is responding really well to calcification in the middle at week 12. Week 24 still seems to be responding, but at week 24, when the scans were showing there was still ongoing extreme response, you see that this KRAS G12D mutation has started going up. And that's when we knew that the patient would progress, and indeed the next scan showed that the patient had progressed. And similar story with this another patient who had again resistance, and you can see that all these clones of G12D, G1213D, they evolved earlier than expected. So what all these examples show us is that liquid biopsies provide us a very clinically meaningful measure of establishing resistance to anti-cancer therapies. And we demonstrated this in these final plots that some patients, when we applied high sensitivity liquid biopsy techniques such as ddPCR or high deep NGS of 100,000 x, we were able to exclude those patients who were normally offered chemotherapy within this context, and they had very poor outcomes. So you'll see the red line, these were the patients who had baseline mutations according to our analysis, and they did not benefit from the treatment. Those patients who had no baseline mutations benefited. And then, so this is the case of negative selection. So what negative selection means is that you could exclude those patients who you offered an anti-cancer therapy which was never going to work for them. The second aspect is positive selection. So we picked up on those mutations which should be targeted differently. So rather than offering them cetuximab or panitumumab, which was never going to work for those patients, we could have offered them BRAF targeted therapy or now KRAS targeted therapies. So there are multiple new therapies which have become available as well. One final question which we addressed was, as I mentioned earlier, whether there was concordance between the solid and liquid biopsies. And interestingly, what we showed was that if we use the same technique, so remember in the lab we use techniques which call the mutation when the mutation has 5% variant allele frequency. But what we were using was 100,000 x, so very deep techniques. So if you apply the same techniques on the solid tissue or the liquid biopsy, you get pretty much the same results, very high degree of concordance. The difficulty though is that in the solid biopsy you're relying on one tumor sample. So you haven't got multiple opportunities to look at that. So then we asked the question whether we could actually forecast resistance. And this is a very interesting concept. So one of the very famous pathologists who I worked with in this paper, Andrea Sobrino from Italy, he said we are failing actually because we have seen our colleagues who predict weather so accurately that we even forget calling each other. In UK actually, if we say what's the weather like tomorrow, people would say it is like 5 degrees and it's almost always 5 degrees. So there is such degree of accuracy. But we are much more behind in terms of predicting when a treatment would fail. So what we projected here and proposed was that what we typically do in chart A, for example, so when the patient has molecular progression, you switch treatment A to treatment B. Normally you wait until clinical progression. So you actually are treating the patient during that time in that pink part of the graph where the patient was never going to benefit. So what you could alternatively do is that you give a break from treatment A, switch to treatment B, if you look at the B graph, and then to treatment C. Or, if you look at C, you can give patient drug holiday for a short time period, resensitize the patient to that therapy, and then eventually restart the treatment. Or finally, what also you can do, which is D, is my personal choice, that you can molecular progression, switch the patient to treatment B, and then re-challenge later on to treatment A, which basically improves the chances of benefit from the treatments. And that's what actually he was suggesting, that we should be able to forecast resistance better than we have been. Now within the same trial, we ran very targeted genetic panels looking specifically at KRAS, BRAF, and RAS mutations. But then we also did whole exome sequencing, that again was mentioned by my colleague earlier. And what we found was that in whole exome sequencing, a lot of mutations were not picked up because it was 100x. However, we picked up new genetic markers such as NF1, which would also confer resistance to anti-EGFR therapies. And this paper was published in Cancer Cell in the same year. Now, another example of a study called Prospect R, which I designed at Royal Marsden, and ICR. And in this study, we had another drug called regorafenib. We did pretty much the same thing. Regorafenib has anti-vascular activities, and therefore we incorporated MRI scans. And that's where I think the multimodal treatment is important. You don't just concentrate on one mode of treatment, but think about how best to move science forward. So here we collaborated with our radiology colleagues and came up with a formula which allowed us to predict, because this drug has anti-vascular activity, so on the MRI scans, in advance of the original scans which were meant to be at 2 months, we could predict at day 15 if the patients would respond to regorafenib or not. And again, when we combine this with liquid biopsy, we found that when you combine the two techniques together, your chances of benefit from the treatment improve significantly. Those were the final results, and this was published in Oncology. Now to the more interesting stuff, which is what I presented so far is quite translational, basic science level stuff. But this is now materializing. So what we see here is in the adjuvant setting, in patients who have colorectal cancer, there are studies like dynamic study, which was presented last year in ASCO and then subsequently in ESMO, and that showed really interesting findings. Stage 2 colon cancer, those of you who treat will know that if you offer adjuvant chemotherapy for 6 months, the maximum benefit that you expect is 3.5%, and there are still significant side effects associated with chemotherapy. So this study randomized patients into 2 groups, 2:1. So one group was patients who had ctDNA positive disease, only those received adjuvant chemo, and the ctDNA negative were given observation. And then the standard management group, which received chemotherapy regardless. And you'll not see more identical graphs in these ones. So what it showed was that recurrence-free survival met non-inferiority. Those of you with interest in statistics would know that non-inferiority studies are very difficult to prove. However, here we found identical results. So what that means is that if the patient has negative ctDNA with deep colorectal cancer, you do not need to offer them chemotherapy if the ctDNA test is negative. And that is again a very good example of how patients' management has been influenced by genetic mutations or their outcomes. Interestingly, even for T4 tumors, which are considered as high risk, there was no difference in the outcomes. Likewise, we look at the overall survival, so you can see standard of care actually numerically, overall survival was 93.3% and ctDNA group was 93.8%. More importantly, if you look at the biological side, so post-op ctDNA, molecular burden, and clearance and relapse-free survival all correlated, meaning that if there was a high variability in frequency, patients had higher risk of disease relapse, and therefore there was more managed offering chemotherapy for a longer time period. So, based on these findings, I'm glad to say that we started that work a few years ago. A lot of other groups got involved, and now there are several trials which are looking at the role of ctDNA in colorectal cancer. I understand that's happening in breast cancer as well and in other cancers. And what they're looking at is, should we de-escalate the treatment, should we escalate the treatment, or should we do anything else? If the ctDNA is negative, it's straightforward. If it's positive, how to make it negative. So the results are currently awaited, obviously. Now, I just wanted to briefly highlight, I treat biliary tract cancers as well. This is a field which was considered dead for a number of years because the outcomes were poor, there weren't many diagnoses, and it was considered as a rare entity. Now, it is now considered as a global health problem. One of the reasons is that carcinoma of unknown primary, about 19 to 20% actually have biliary tract cancers. So it was underdiagnosed in the past. And this field again has changed. This is a paper that we recently published and demonstrated that there are several targeted therapies based on the genetic aberrations which are found on the tumor cells. So FGFR, HER2, RAS, RAF, BRAF mutations, all of these you will see from this diagram there are drugs available to target these mutations. And we have actually treated a large number of patients at University College London. In the interest of time, I haven't included the whole data, but this is worthwhile looking at this paper. It's precision medicine for patients with biliary tract cancer. And what we showed was that there were very common mutations found in these patients when we did a foundation medicine panel for a lot of these patients. And those who were able to have targeted therapies, so normally those who treat biliary tract cancers would know that the overall survival rate is from 6 to 9 months. However, if the patients had the right mutation status, their overall survival was 29 months. And their median PFS was 9 months, which is almost as good as their overall survival based on other data. And what we showed was that it does not matter whether the treatment is offered in the first line, second line, or third line setting. As long as they have the mutation, they are fit for the treatment, their outcomes were excellent. And again, if you look at all the targeted therapies now available in these cancers, you'll see that the whole treatment pathway has been transformed with patients being treated with ivosidenib if they have IDH for mutation, trametinib and regorafenib, with BRAF mutations, tucatinib with FGFR2 amplification. Interestingly, if they develop resistance to these therapies, and those of you who are hematology colleagues will know that you can even pick up on those acquired mutations and target them with new therapies. So that is all very exciting field. So I actually wrote this paper and proposed that in future, this is how the biliary tract patients should be treated. So currently, if they have unresectable disease, they don't get sequenced. So I sequence my patients, particularly in the private sector. If they have any potentially targetable treatment options, I will go with them first, and then I will switch to the standard of care, which is gemcitabine and durvalumab, and then go by the mutation status of the tumor and repeat biopsy at time of progression. If they developed a new resistant clone, you can target that as well. So that takes me back to the initial question that I had asked: should liquid biopsies enter clinical practice? So, in my view, the guidance of treatment in metastatic disease has already changed, and I feel that my practice has changed based on that. Guiding treatment in stage B colorectal cancer, my practice has also changed. I don't offer them chemotherapy unless I've got a negative liquid biopsy test. Now, in the final part of the talk, I will just take you through some of these cases just out of interest to show you how in real life, in clinical practice, things have changed for my patients. So this is a patient with GOJ cancer, and she came to me because I was treating one of the celebrity patients who had luckily, which I'll discuss later, but she went on telly and discussed her case. So she came to me with locally advanced gastroesophageal junction cancer, and you see, unfortunately, on a PET scan, there were widespread metastases, including lymph node mets and even bone mets. Now, typically, these patients have a survival of 6 months or 6 to 9 months. And she came to me and she said, "I've seen on the television, you have to cure me." And I said, "Unfortunately, that's not in my hands, but we'll try our best." So again, I sent her foundation medicine test. This was a time when immunotherapy was not licensed in gastroesophageal cancers, although there were some trials ongoing. And I found that her CPS score was 65. So I started her on immunotherapy combination, nivolumab and FOLFOX. And very surprisingly, you see 3 months later, you see a very clear PET scan. Again, 3 months later, maintained CMR. Now, September 2022, almost a year later, she was found to have this very small focus of disease in the gastroesophageal junction. And that's where I would like your attention. Because in a normal MDT, where you're not paying too much attention to the case, because we have hundreds of cases in MDTs, it could be considered as progression, and you would say, let's stop immunotherapy because this patient has not progressed. However, I had a debate with my colleagues and I suggested that we should do chemoradiotherapy with curative intent because that is just a single focus of disease. And thankfully, I was just able to convince them. So we carried on with immunotherapy and we treated this with Taxol, carbo, and chemoradiotherapy aggressive approach. And in January 23, May 23 complete remission, July 23 complete remission. In fact, this lady had recent scan in January 25 and she remains in complete remission. So this is, a great case from 2021 up until now, 4 years complete remission of this patient. Now this is the second case that I was alluding upon earlier. This is a lady who was Lady Diana's fashion designer, and I was asked to see her because this was the day when COVID was declared as pandemic. So she had cholangiocarcinoma with widespread metastatic disease, and the GP called me and said, "Can you please see this patient and tell her that she's for TLC, tender loving care." When I saw her, she was 77, 78, but she was absolutely active, working full time. I said, "Well, it's not for TLC, there's no biopsy." So we did the biopsies, we sent the liquid biopsies, and then she was found to have MMR deficiency, which is exceptionally rare in cholangiocarcinomas. Then I had to fight with the insurance company to get her pembrolizumab, and actually, down the line, up until now, she's completely cured. So it helped me as well because she went on all the television interviews, introducing me as well. So, not that that is the main reason why we should treat patients, but you get those advantages sometimes. This is the final case which I would like to discuss, and it's really interesting. This is a 28-year-old man, Greek etiology. He was diagnosed with rectal adenocarcinoma. Have a look at his PET scan. You'll find no liver damage. Everything was replaced by the cancer cells. And he came to my clinic obviously very upset. His mother said she wanted to donate her liver to him, and unfortunately, I wish I could say yes, but we have no way of changing the livers so far. So I did the foundation medicine test, and again, my colleague earlier mentioned about Pol D mutations. So this patient had Pol E mutation. And then again, no evidence to show that immunotherapy works, but there were 3 case reports in uterine cancers where immunotherapy had worked. So we had a long fight with this insurance company. We managed to get pembrolizumab, and this is all the way since then. He's basically in complete remission since October 2020. So look, all these cases were important because I wanted to highlight that a lot of these things when we see in the talks or in the papers, we feel that they're probably not real life. I've got experience of that sitting in a very high research active center. There are lots of examples. I mean, in pancreatic cancer, in the interest of time, I can't show the data, but we've got around 45 to 50 patients with metastatic pancreatic cancer who have done better than 2 years of survival. So I think the key is that every patient is important, and we need to pay attention to their needs, biological needs, as well as clinical needs. And in conclusion, liquid biopsies in my view capture spatial and temporal heterogeneity, and it underpins the resistance to anti-cancer therapies. However, dense sampling is needed to predict failure of the treatments, which means that you do frequent samples, and tumor genetics help informing the decision making in significant proportion of oncology patients, which is different to how it used to be. Because previously we only offer patients planned chemotherapy without any thought about how this individual patient will have a reaction to that treatment. And I think finally, last 2 slides are dedicated to the team which works with me in the research center, so it cannot be done without their help. So in my view, the key to successful research is collaboration and, more importantly, respect. And I learned that hard way because a lot of research nurses were involved in the clinic. They do a fabulous job, so it's really appreciation of everyone. And then broad research development goals include building relationships, trying to start clinical trials, improving the research portfolio, and patient involvement. And we will be glad to hear that side of the job. Thank you very much.
Thank you very much, Dr. for such an inspiring talk. Definitely, it's creating precision oncology in action. Now is our third speaker, and it is an absolute honor to introduce an old friend and a leader Dr. Fawzan Raya. Dr. Fawzan is the Chief Medical and Genomic Officer at Balfira Omics, a Professor of Human Genetics at Al-Faisal University and adjunct Principal Scientist at the Center of Genomics Medicine at King Faisal Specialist Hospital and Research Center. He graduated first in his class from King Saud University, completed his pediatrics residency at Georgetown University, and pursued fellowship in clinical and molecular genetics at Harvard Medical School. He also conducted postdoctoral research in developmental genetics at Harvard. Dr. Fawzan has published over 590 high-profile papers, is frequently invited speaker, and serves on the editorial board of major human genetics journals. His work has awarded him numerous awards, including William Dean Bose Award in Medical Genetics, King Salman Award for Disability Research, and the ASHG Care STEM Award. He will give us a talk today titled The Patterns of Inherited Cancers and the Genomics Technologies in the Kingdom of Saudi Arabia. Welcome to the Fawzan.
Good afternoon, everyone. First, I'd like to thank my good friend, Dr. Rashid Makki, for a very kind and generous introduction. I'd like to thank the organizers for the very kind invitation. It's such a great honor to be with you today. Really excited to be with you because I do believe that medical genomics experts and oncology experts need to talk to each other more often because we have this shared goal of realizing precision medicine, in this case, precision oncology. Let me tell you something. In genomic medicine, we are very excited by the developments that are happening in precision oncology. In fact, we always quote you guys as the celebrated success of genomic medicine. So I hope it's not a one-way love affair. The fact that I'm here tells me that it's being reciprocated and you guys do care about our input. And so I'd love to share with you of all the exciting things that are happening in the space of precision oncology. A little sliver that I was asked to cover today, which is hereditary cancer, and what is it that I can share with you to hopefully help you make this something to think about as you see your cancer patients. So let me start by dispelling a few myths. Myth number one is that hereditary cancer is rare. It's not. Hereditary cancer, you've heard it from my good friend and colleague, Adia, that it is responsible for 5 to 10% of cases, right? So here is an example of a study that was conducted at the Memorial Sloan Kettering Institute involving more than 1,000 cases of advanced cancer. And you will see that they found, and I don't know if I'm going to be able to handle this pointer. But anyways, they found that 17%, 1/7, of all these advanced cancer are actually hereditary in nature. And of course, if Memorial Sloan Kettering does something, then Dana-Farber Institute will do something bigger, right? So this is a much bigger study done by the Dana-Farber involving more than 34,000 cancer patients. And what I love about this study, apart from the sheer size of the cohort, we're talking more than 34,000 patients, is that they highlighted for the readers the fact that these cancers fall under 2 different categories, right? So group 1 are those cancers for which there are guidelines for you guys to consider testing for germline, right? Let's call them group 1. Your bread and butter, the breast, ovarian, colorectal, and so forth. But then I want you to pay attention to group 2. These are cancers for which there are no guidelines. You are left on your own to decide, is it worth testing my patient? And let's call them group 2. And what's remarkable is, obviously they found that a big percentage of patients in group 1 did turn out to have germline variants, up to 13.8%, almost But look at group 2. Group 2 also had a quite sizable contribution of germline cancer, 6.6% in the case of bladder. So really, two take-home messages from this study. One is about 1 in 10 of patients who walk into a clinic as cancer patients actually have hereditary form of cancer. So it's not rare. B, if you were to just wait for guidelines in order to consider testing your patients for germline, you will be missing a lot of your patients. And to me, that's just unconscionable. And more about that later. This is the study I was talking about. And just unfortunately, the laser pointer isn't working. I just want you to pay attention that this is group 2 up there, and this is group 1 in the bottom. And you'll see that some of the cancers in group 2, for which there are no guidelines, have a higher percentage of germline compared to group 1. So it makes really no sense, the fact that they're excluded from germline testing just because there are no guidelines. I want you to keep that in mind going forward, please. Okay, time for me to debunk myth number 2. That for some reason hereditary cancer is exceptional in clinical genomics and in genomic medicine. It's not. So, when I was a fellow, one of our rotations was to rotate at Dana-Farber Institute and, to sit with these cancer patients and for their testing and counseling and so forth. And it just struck me the amazing contrast between that experience and the experience of regular clinical genetics. And by that, on top of that, I'm referring to the fact that there are so many hereditary cancer syndromes, as nicely highlighted by my colleague Adia in her talk. And in Dana-Farber, they would have to go by the book. The patient has to fit the exact description of that syndrome in order to be able to justify testing that patient for that gene. And it just struck me because in clinical genomics, even at that time, we were pretty liberal. If we're suspecting something, we would test for it because we believe there's some benefit to the patient. In cancer, it seems to be the complete opposite. Unless you have any reason to test that patient for that gene, you just wouldn't do it. And so I've always asked myself why. It makes no sense. What's different between all these syndromes? When we know that, every clinician knows that patients don't read textbooks, right? So they present the way they present. And it's very rare for a patient to be a very classical textbook picture of that disorder and every aspect of that syndrome. And it's not fair for you to expect a clinician to be always perfect in picking up all these subtle signals that will tell you that this is the syndrome A or syndrome B, right? So why put the patient under the mercy of that clinical intuition? Why not just test the patient and get the benefit? And what really bothered me even more is that unlike the many settings in which we do testing in clinical genomics, testing for hereditary cancer is even more clinically relevant, right? Until recently, as you know, most of the clinical genetic conditions that we deal with are not treatable. So for the most part, we've been testing them for prevention and things like that. But in cancer, it makes a huge difference if your patient is positive for germline DNA, right? First of all, and you've heard the beautiful talk by our guest speaker, Dr. Muhammad a while ago, about how to personalize your treatment options. So if you're someone with germline BRCA2 for instance, you would be a perfect candidate for PARP inhibitor, right? If you're a patient who tested positive for Lynch syndrome, you would be a perfect candidate for immune checkpoint inhibitor and so forth. And second, finding that germline variant is going to enable you to personalize the future cancer risk management of your patient. And again, I don't need to tell this audience what I mean by this. You can tailor the surveillance program for your patient, even prophylactic surgery for your patient in case of FAP, for instance, or hereditary breast and ovarian cancer and so forth. And third, and last but not least, risk assessment for relatives. Even 50% risk of having inherited the exact same variant identified in your patient, because for the most part, these respiratory syndromes are also dominant. And you can effect primary prevention by identifying these individuals, preventing the cancer before it even happens. So you want to tell me that with all these benefits, there isn't really a huge incentive for you to look for that germline variant in your patients? I hope you agree with me that that should be the case. And in fact, labs have taken matters into their own hands. So this is an ad by one commercial lab, for instance. It's advertising for patients directly, reminding them that even if your clinician is lousy and is not considering the possibility, please trigger your physician to think about it if you're a cancer patient. 1 in 8 people with cancer have hereditary form of cancer. And they're reminding them that if you do have a germline form of cancer, there's a good 30% chance that your variant is going to guide the therapy for your cancer. And the last component, which I think is scary, and I want to pay attention to this part of the advertisement for a moment, where it says nearly half of the patients have negative family history, meaning almost half the patients who do test positive for these hereditary forms of cancer, they don't qualify for the guidelines that would otherwise tell you, oh, go ahead and test this patient. So Adia, beautifully presented to us, for example, how we should consider hereditary form of cancer, that there's positive family history, there's this, there's that. But this will only highlight, a fraction of patients. If you only go by these criteria, you will be missing a lot of cases. And so the question is, why not sequence all cancer patients as a matter of routine clinical practice to identify hereditary forms of cancer? Now, in all fairness, if you were to ask me this question a while ago, let's say more than 15 years ago, I would have told you that's just technically almost impossible. And sorry for the molecular biology 101, I just want to remind you of how things really progressed in the field. So until about 15 years ago, the only way to identify a variant, you probably noticed that I'm avoiding the term mutation because we like to say variant in genomic medicine. So please, when I say variant and mutation, they're interchangeable, but we love the term variant. So in the old days, for you to identify the variant, you will have to go through the classical standard sequencing method, which requires you to amplify a specific fragment of DNA, and then you can sequence that fragment of DNA. That's it. So you really need to think of one single gene and amplify it and then sequence it. And even then, it's really expensive. So thinking of sequencing a patient for a bunch of genes, that was just out of the question. Not just technically, but the cost was just completely prohibitive. And then came next generation sequencing. Like, all the beautiful applications that Dr. Khan was talking about, the liquid biopsy and serum liquid biopsy, this would have been impossible without next generation sequencing, which allows you to amplify so many segments of DNA and sequence them in parallel. That's why we call them massively parallel sequencing. So now all of a sudden, you have the technology to sequence every single gene that could be relevant for your patient at a tiny fraction of the cost it used to take for you to sequence one single gene. And so this could take the form of panels, like the foundation medicine panel that Dr. Khan was talking about, where we have a bunch of genes, 30 genes, 100 genes, 500 genes. You can design it the way you want. It could be an exome, treat the whole genome, right? So now that the technical hurdle is out of the way, and the cost pretty much is out of the way, I think it's very reasonable for us to pose the question again. Why not sequence every single patient with cancer to make sure you're not missing hereditary form of cancer? In fact, I would go even more bold and ask, why not sequence every adult for a hereditary form of cancer? I mean, think about the potential, right? I mean, if you identify someone in the general population as having a hereditary form of cancer, you cancer is a timing game. You know, the sooner you play the game, the more likely you are to win the game, right? And so being able to identify all these asymptomatic or pre-symptomatic healthy adults who actually have cancer because of this, you know, massive screen for hereditary forms of cancer, to me, sounds like a terrific idea. And of course, it goes without saying that if you can test all your cancer patients, you can in fact tertiary prevention by guiding therapy as we talked about. So if you ask me, I really think this is a missed opportunity. And let me show you one piece of data to support that. This is a study on just healthy adults in the US involving more than 44,000 adults. They were told, hey, if you're interested in being checked for hereditary forms of cancer, come to us, we'll do for you for free. And they found, by the way, they only tested for hereditary breast and ovarian cancer and Lynch syndrome. That's it, these two forms. And we all know that we have tons of others. And if you do this, 1 to 2% of your healthy population are actually positive. And just think of the opportunity you have there. And again, remember that ad I was telling you about in that DK ad where they're talking about half the patients probably wouldn't qualify. That's exactly what they found that study as well. 40% of those adults would never have qualified for someone like Adam to say, yeah, you deserve to be tested. Because they simply lack the family history and the other criteria that would otherwise make you think of potential hereditary form of cancer in the family. So, how about our local population? I still think there's also a great missed opportunity by not doing routine hereditary cancer testing. So this is a study I conducted with my sister. You probably know her more than me because she's a cancer researcher found at Cradle. And we asked the question, what if we can think of a scenario where if you cancer patient at King Faisal is actually tested for hereditary form of cancer, right? So we took all the samples we collected over the years, more than 1,300 cases involving breast, ovarian, colorectal, and thyroid. And again, the numbers were absolutely staggering. So we're talking 16% of all these breast cancer cases were positive. 23% of ovarian cancer cases were positive. 10% of the colorectal cancers were positive. And look at this thyroid. Who would have thought? 3% of thyroid cancers actually were hereditary forms of cancer. And what's more concerning really is all these nice things that Anya talked about to predict the possibility of hereditary forms of cancer. They're great when your resource is limited and you really need to know how to spend your money. But if you really want to care about giving your patient their best chance, that should not stop you from doing the test. Look at this. If you look at the age, so if you say, no, I'm only going to do it for those who have young age of cancer, it was completely useless in every single form of cancer. The stage of cancer is completely useless in predicting who's going to test positive, who's going to test negative for hereditary forms of cancer. And, in the case of family history, it was useless for breast cancer and thyroid cancer. Of course, if we have MSI stability, it did predict positivity for Lynch syndrome, but that's really with the exception. For the most part, there was just no way for us to tell who's going to test positive, who's going to test negative. And I truly believe it's in the best interest of patients to have every single cancer patient tested for hereditary forms of cancer. Now, people have looked into economics because it always comes down to money, unfortunately. And without getting too technical, whether you're looking at testing every single cancer patient for hereditary forms of cancer, or even population screening for hereditary forms of cancer, the balance is really tipping in the direction of just do it because it's actually the cost-benefit analysis is highly supportive of this being beneficial. Now, I'd be remiss to leave you thinking that the only problem we have when it comes to testing every single cancer patient, the argument against it is purely economic. That you're spending too much money and you're only picking up goes around 10%. I will also try to debunk another myth for why a lot of people are very, very conservative about testing patients for cancer panels. And that is the boogeyman, the VUS that I talked about, variant of uncertain significance. Again, clinical genomics 101, bear with me. Just to remind you that when you sequence a gene or a genome, you're going to find variants, and you're going to have to classify them formally as follows. According to the American College of Medical Genetics and Genomics, if a variant is more than 99% likely to cause the disease, it's considered pathogenic. Okay? If your variant has only 90% chance or higher of being a disease-causing variant, we call it likely pathogenic. If your variant has 99% likelihood of not being disease-causing, we call it benign. If it has more than 90% chance of not being disease-causing, we call it likely benign. So what's in between? You guessed it. Variant of uncertain significance, VUS, right? And it's almost ridiculous to think that we are equating a variant that has 11% likelihood of being disease-causing with a variant that has 89% likelihood of being causal. We call both of them variants of uncertain significance. And so it's understandable that a lot of people are so concerned, well, if you test the patients, you're likely to identify VUSs. Then what do you do with these VUSs? You've heard Annie talk about the problem she had to deal with VUSs, right? And of course, it's a number game. The more genes you test, the more VUSs you're likely to encounter. But they have a counter argument. How is this different? And again, I'm glad I'm not an oncologist. How is this different from someone arguing, you know what? You shouldn't be doing mammograms because, there's a good chance you may find something in the mammogram that you cannot explain. I'm sure all of you are going to say that doesn't make any sense. And I would argue it's the same argument here. Just because you may encounter a variant of uncertain significance doesn't mean that you just not test the patient and make them benefit from genomics. There's got to be a better way to handle this. And one way is to improve the classification. As I told you, it is ridiculous that a variant that has 11% likelihood or 89% likelihood of being disease-causing are both called variants of uncertain significance as one category. And that's something the American College of Medical Genetics and Genomics is actively working on. Hopefully, within the next few months, there will be an update of that classification. But I'm excited to share with you a recent breakthrough to really conquer this problem of variants of uncertain significance. Once and for all, just get rid of it, hopefully, right? And this is one of the techniques that's called MAVE, massively parallel assay of the effect size of the variant. Now, the idea is simple in theory. It's quite challenging technically, but the results are beautiful. What happens is you use CRISPR to metagenize the gene. It's called saturation metagenesis. You pretty much introduce every possible variant in your gene of interest, and then you put that construct through a rigorous functional assay. And so here's an example of what they did for BRCA2, for instance. So they introduced every single BRCA2 variant they can think of. They put it through a rigorous test that's dependent on the fact that there's, as you know, homologous DNA repair defect in these patients, and see if the variant would cause it or not cause it, right? And as I told you, the results are absolutely beautiful. Look at this. So before this assay, almost 40% of the variants in BRCA2 are variants of uncertain significance, and now you're able to shrink this and follow this from almost 40% to nearly 11% of cases, right? So just think about it. The more VOSs you're going to have to deal with. And so this is really an exciting development. And again, another reason for me to say, fear not, do not fear VOSs. Just go ahead and test your patients because it's really, really worth it. Okay, in the remaining few minutes, I'd like to consider also the testing strategy. So, how do you test your patients for germline hereditary cancer predisposition? Well, one could argue you could start with a tumor sample. Again, we've heard beautiful examples from Dr. Khan how profiling your tumor sample can really, really inform the management of your patient. And oh, by the way, while I'm profiling my tumor sample, I've identified the germline variant. So pretty much two from the carcinoma, right? Alternatively, there is the approach of doing paired testing. So you test the normal tissue and you test the tumor tissue in order to specifically identify your germline predisposition with high confidence. So those who argue for the carcinoma approach, you can't fault them. If you remember when the COVID numbers started to decline, the number of positive cases were small, labs used to batch samples. I don't know if you recall this. So they would batch 50 samples at a time, and they would mix them together. So only the batch that is positive, they would then go back and test every single case within that batch, right? So same idea. Most patients, as you heard, do not have hereditary forms of cancer. So why not start with the tumor, profile the tumor, and pay attention to see if there's any germline variant to be picked up from the tumor. Yes, it's efficient, user-friendly, saves time, saves cost. But again, I don't have time to tell you, it's actually quite challenging to identify the germline variant from the tumor sample. It can be done, but it has its own limitations. Honestly, my dream is that we follow on the footsteps of this pioneering project that was initiated in the UK. If you're from the UK here, you have every right to wave the flag because you guys have been truly pioneering in this space. This is the so-called Genomics England project where the UK government decided to use whole genome sequencing on 100,000 patients in the UK. And a big chunk of that project is dedicated to cancer. And so what they did was, they took cancer cases from around the country, and you can see all kinds of cancer, and they would just do whole genome sequencing. Forget panels, forget exomes, just give the patients the best available technology available. So you do 100x whole genome sequencing, that's very high depth for the tumor, and 30x for the normal being, typically derived from blood, sometimes from saliva or skin biopsy. And the results were absolutely beautiful. So you get pretty much everything. Look at this. You get full profiling of the cancer of your patient, and what you see in pink on the left-hand side is the percentage of cancers for which within each cancer, the percentage of having a positive tumor finding that is actionable, for which there are guidelines. We just heard the beautiful examples by Dr. Khan on cases that were pretty much hopeless, but it was through their tumor profiling he was able to identify actionable variants that completely changed the course of their management. And that's exactly what they found in these cases in a reducing percentage, starting from glioblastoma all the way. And what you see on the right-hand side, and I apologize for the pointer isn't working, is the percentage of the germline variants they identified. And like a bonus, by the way, since we were doing whole genome sequencing, they also reported the genome profile at the end because that's very, very important if you're giving your patient many of the cancer-related therapies. Okay, in the last couple of minutes, I'd like to share with you something really, really exciting that is happening in the space of hereditary cancer predisposition. All throughout my talk, I've been telling you about what we call not 100% of all cancer, right? So we know there is what we call penetrance issues. Not everybody with a BRCA1 is getting all cancer. I want you to think about this for a moment. How come two ladies with the exact same BRCA1 variant, one of them is going to develop cancer in her 30s, and the other could live well into her 60s without ever developing cancer? Why? Same variant. Now, we do have a hint about why from studies that show that those with positive family history are more likely to have a higher penetrance than those with negative family history. What do you get from family history? Family history gives you exposures, but also gives you a shared genetic background. So we know that other than these big players that everybody knows and loves, BRCA1, BRCA2, and all these genes, there are so many other genes involved in carcinogenesis. So it's very likely that there is this polygenic background that is either protecting you from cancer or predisposing you to cancer. And so this is the field, it's called polygenic risk score. And it's really, really exciting development. Finally, we're able to quantify this background polygenic risk into a score that we can give you. And what's really remarkable is, think about it. If you're someone with BRCA2 or BRCA, let's stick to BRCA. If you have BRCA1, two individuals with the same BRCA1 variant, one person can have a penetrance up to 80% because they have a very high polygenic risk score, and another person could have a lifetime risk of cancer of less than 20%, almost approaching the average for a particular age group. So it's almost like a dream come true if we're able to combine that hereditary form of cancer predisposition with the polygenic predisposition. And that's exactly what's happening in some cases. So this is, I took this from Myriad Genetics. If you request a breast cancer testing on your patient from Myriad, not only do they test for the genes we all love, but they also quantify the polygenic risk score of your patient and they report it back to you. So what you're seeing here, this is a woman who presented to, let's say, to Alia, and she said, she told her about this very strong family history, and she's very concerned. So Alia thinks, yep, this is a case that we should test for breast cancer predisposition. She sends the test to Myriad, and Myriad tells Alia, listen, your patient is negative for BRCA1, BRCA2, POLA, and all these genes, but your patient is still higher than average because of her polygenic risk. And so this is the future of hereditary cancer testing that we're going to be reporting to you the big players and also the polygenic risk score in one combined score that I hope you find very helpful in your practice. So I'll conclude. Hopefully I've convinced you by now that mendelian predisposition to cancer is common, clinically relevant, under-recognized, and under-tested. I'm hoping you guys are going to change that. The new genomic tools enable inexpensive and high-throughput testing of germline cancer predisposition, and as such, they truly upend the old paradigms of who to be tested and who not to be tested. And cost-benefit ratio is increasingly in favor of doing this universal testing. I hope I convinced you that VWeb's challenge is no reason for you to refrain from testing your patients, and I showed you a glimpse of how we're going to be reporting mendelian and non-mendelian predisposition in our reporting going forward. And with that, I conclude my talk, and thank you very, very much for your attention.
This insightful talk, and I would like to invite our speakers to the stage.
two common things if you really decide to do the surgery in person and the decision on the basis of that, which we are not doing right now, but probably is not in the NCCN guideline yet at all. But if you are doing it, then how long after surgery you will do the surgery 3 months? Because that's relevant. And is it just yes or no question, or there is a quantity of that response?
No, that's a great question, actually. So, is that what mine is? That should go. Is that clear? Can you hear me? Yes or no? Is the audible? I can hear you. Just get the microphone.
Is that better? Yes. Okay. So no, that's a great question. So there are different types of methods available now. So if you do foundation medicine test, that only gives you an answer on low or high frequency of ctDNA presence, so less than 1% or more than 1%. But there are some specific methods which are actually really made for this purpose. So for example, guarded reveal is one of the methods, which actually tells you whether there is any fraction of ctDNA or not. So it's a matter of choosing a method which is specifically geared towards this, answering this question. Because if you go for a broader method, that would be looking at certain mutations, and in parallel will give you an answer about the ctDNA fraction. And that will still not give you an absolute answer. So far actually, there are just two methods. So one is guarded and the other one is 10%. They do the same thing. CARES is another one, but they need the tissue as well. So different methods and pros and cons, but in the end, yes, what you want is a method which gives you an answer in yes and no. Because if it gives you the fraction, so any fraction, whether it is low, even if it is low but positive, would still manage chemotherapy.
Assalamu alaikum. Thanks to all speakers. My questions to Alia. Cancer is genetic but not inherited. When should we start referring our patient to genetics clinic? And to Dr. Dania, where are we at King Faisal Special Hospital in Noor? Do we have this established or can we refer our patients? Thank you.
Thank you for the question. But now we have to. I started by explaining that there is a criteria for referring patients for genetics, and that's what we used to do before, and maybe that's the old school. What we do is we look at if our affected individuals in the family with cancer, so there's a strong family history of cancer. If the affected individual is less than 50 years of age, if you can see multiple individuals in all the three generations, for example, with cancer. If one person affected with two types of cancer, if they have bilateral cancer, then we suspect that this individual should be referred for genetics, for genetic testing and counseling, if indicated if it comes that the result shows a pathogenic germline variant. But what has Dr. Priya just explained now is a new way of looking at patients with cancer. So Dr. Priya, do you want to answer your part?
I think everything I said makes sense, but when you start looking at it, made sense in the past when A data was available, B testing was expensive. But now we look at the data. If you do this, if you only refer your patient who has breast cancer at the age of 30 and she has 3 sisters with cancer, her mom with cancer, if you only refer these cases to ADMA, I guarantee you will be missing at least 30% of cases who actually do have germline predisposition to cancer, and they're just missing. And so, really, the new trend now is just test all your cancer patients, because we know around 10% of them are getting positive. You might think, yeah, but that means I'm testing 90% for no good reason. It's not really for no good reason, because the 10% are absolutely worth it. Those 10% who are positive, and again, I could meaning you would have missed, for the most part, if you simply go by the, classical guidelines, you miss out on all these benefits that you get for these patients. There isn't really a good way around it. Whatever criteria you use, you will be missing cases. And it's up to you. If you're the kind of person who would say, I'm willing to miss a few of these patients in order to save a little bit for the hospital, fine, go for it. But if you're the kind of person who says, I will give my patient the best possible, shot, then I will definitely test all blood cancer patients. But I think Dr. Daniel has something to say about Professor Medina.
Regarding the clinic in Medina, I'm taking care of the general genetic clinic. I see pediatric and adult patients, not specifically for cancer. However, I saw many cases of incidental finding, as what Professor is saying. We miss these cases because patient is asymptomatic and may have no family history, but when we do the testing, the whole exome sequencing for one thing, we find genes related to cancer, like TP53, so cases of Lynch, and others. There's also cases that they came to me with intellectual disability. That's the main reason for visiting the genetic clinic. And the patient had a history of leukemia, and we found that he has Noonan syndrome, and he never had any genetic testing and wouldn't have it unless he had this intellectual disability. So I agree with Professor about doing more of genetic testing for patients with cancer.
So this is Aswara from Providence Comprehensive Cancer Center. My question is for Forum. You mentioned a few patients of pancreatic cancer who could benefit from nuclear biopsy. From our institutions, we are seeing a lot of false negatives, and we do not see the window of opportunity, which is very short, for treating pancreatic cancer patients. Even if we detect those ctDNA markers, it's too late to make a change, except for giving the more chemo. So what's your opinion for this particular disease?
That's an important question actually, and sorry, when I mentioned about the outcomes of pancreatic cancer patients, it was not necessarily just based on liquid biopsy findings. So it's slightly off the topic, but with the pancreatic cancer patients, I tend to treat them until progression. I think that's the key in my view, because if you start the treatment, the traditional way of treating these patients is giving them 6 months of treatment, and you become concerned about quality of life. And it's a long debate as to whether it really affects the quality of life within the context or not, because particularly with these patients, we all know that they end up having memory obstruction, other problems, and then that disease-related effects jeopardize their quality of life. At the same time, I've done liquid biopsies in my private patients, which is about 50 of them. And 3 or 4 had their treatment pathways influenced. They had PALB2 mutation, one had a BRCA mutation, so just the common pathways. And recently, as you know, the KRAS G12D mutation is pretty common as well, and there are trials which are recruiting patients with those mutations. So eventually, I think one thing we all need to remember about the evolution of cancer genetics is that you will not have the results based on cancer genetics straight away. Even those examples that I've mentioned. Of course, I've treated several patients that I've mentioned, handpicked ones. But the main point about thinking about those even small number of mutations is that 2 things. One is that the science evolves. So it is possible that today we don't have a proper KRAS inhibitor, but there are pan-RAS inhibitors or other things, and we know that KRAS mutation is present in 90% of the pancreatic cancer patients. So that information itself is critically important. And then the second aspect is that even if it is like 10% of the patients, 5 out of 50 patients who have a BRCA or similar type of mutation, and they can benefit from a PARP inhibitor. For that particular patient, it does not matter that the remaining 90% do not have that mutation. So obviously it affects the economics and the burden of the resources, etc. But if you come down to precision medicine and individualized care, that particular patient deserves the best possible care.
So, I have one question to Dr. Fawzan. Yeah, another question to Ali. So for Dr. Fawzan, we are observing incidence in very young patients, especially breast and colorectal cancer. We see those adults in their 30s and early 40s in Saudi Arabia. So I was curious to know whether this is actually supported by data, and if it is, what could be the reason? And for Alia, I'm also asking about the practice of counseling patients with BRCA1, BRCA2 mutated cancer, breast cancer, by medical oncologists. So we increasingly see those patients and we talk to them ourselves, and also the breast surgeon about the diagnosis, the finding, and the consequences, without actually sending them to specialized counseling. So I just want to know your opinion on what you think of this practice and whether there should be specific training regarding this.
As you know, unfortunately, we don't have very good registries in the country. So most of, like what you talked about, they're like observations, and there aren't really very solid data, epidemiological data to prove a trend, except I know that there's been, at least to the best of their capabilities, the folks who work on the colorectal cancer, there is evidence suggesting that we do tend to have earlier age of onset. And we think at least part of it is, and part of it is actually published, there is a recessive component to colorectal cancer. So maybe that is contributing to an earlier age of onset. There could be other reasons as well. I'm not aware of any solid epidemiological data that prove that we tend to have a younger age of onset for breast cancer.
Salam.
Second question for
Regarding cancer patients with BRCA1 and BRCA2, it's very important when we see the patients in the clinic that we start by taking the family history and to know who exactly is at risk in the family. And then we explain to the patient what the patient is at risk for. For example, for females, the most important part with BRCA1 and BRCA2 is breast cancer. She's at almost 80% risk of developing breast cancer, which is considered the highest, and 40% risk of developing ovarian cancer. And then we move to pancreatic cancer, which is low, melanoma, which is low as well. And if males in the family, they should be screened at a certain age, for example, after 60, or they are at risk of prostate cancer. So these are the most important parts, what they risk for in the future. And also, we need to tell them about the surveillance, how frequent they should be screened, for example, for mammogram and for ultrasound, and even for ovarian ultrasound. Also, we should tell them who is at risk in the family, and we explain about the siblings, what's the chance that they could have the same pathogenic variant. And we plan with them to bring the family members for counseling and for genetic testing as well. And we try to provide them with You mean reduced penetrance pathogenic variants? Yeah. Well, we offer, yeah, exactly, we offer, since the patient has the pathogenic variant, we offer prophylactic surgeries, but from my point of view, I suggest that they start thinking about it when they are done with lactating and they are done with having the children that they want, will parallel with the annual screening. So I keep explaining that early detection of cancer raises the surveillance rates very much. So it's better if you're planning to have children at the meantime, then you go with the survey, you go with annual screening, surveillance, and decide on the date when you want to go for prophylactic surgeries. Yeah.
So you don't push it very hard like the other pathogenic variant that we know that it was cancer, like more likely than other variants?
Well, if the patient is normal and not affected, it's very difficult to ruin their lives by pushing for these surgeries, especially females. They'll be affected if they didn't start their families yet, or they're in the middle of reproductive age. Then it's very hard to push them to just go for prophylactic and yeah, stuff.
I think by this we can thank you all for the speakers, Dr. Craig, Dr. Khan, and Ms. Ali Gary, Dr. Makki for being with us here, and thank you for the audience for their listening. The speakers will be around in case they want to catch them for any questions, and this is the stage for the announcement.
Thanks everyone. It's almost the Maghrib prayer now, so there is a male and female musalla for in the venue, for female on the right side, for the male in the corner, and we will be back at 6:30 please sharp, because we'll start the Saturday symposium, followed by our next session. For the speaker and moderator, please join us for the coffee break and the speaker launch. Thank you.
Last time I saw this guy, 31 years ago. Yeah. And now I see, whoa, what's from the past? Yeah. This is hard.